Thank you. Good morning, everyone. For those of you who do not know me, my name is Fatmata Williams, and I'm the Deputy Medicaid Director and co-author of this maternity bundle. And I'm excited that we are almost at the end of the first performance year. I do want to welcome you to the forum and thank you for the partnerships over the months. We do appreciate all of the questions. And as you heard, Tiffany, this is going to be a busy agenda, so I will not take up too much time. So, Tiffany, I will hand the mic over to you.
Wonderful, thank you. All right, so we'll kick off with our basic ground rules, which most of you have already probably seen. So first and foremost, this meeting is going to be recorded. We'll also share the meeting slides on our DSS website, so you'll have access to view this later. We ask all participants to mute yourself if you're not speaking. If you'd like, you're also welcome to introduce yourself in the meeting chat by entering your name and the organization's name in the chat that you're representing. Otherwise, we ask that you limit the chat unless you have other technical difficulties. We'll be directing folks to use the Q&A feature at the bottom um, to submit any questions that you have. In terms of questions, like I said, we do have a lot of content that we want to get through, so we're going to actually hold all of the questions towards the end of the presentation in the dedicated Q&A portion. We ask that you specifically focus your questions on the case rate refresh process. So we won't be taking any provider specific questions about your rates, but if you have those questions, we're more than happy to set up time to discuss those at a separate occasion. And otherwise, all materials, like I said, will be posted to the DSS website. Next slide. In terms of our agenda for today, I'll pass the mic next to Sean to go over some quick introductions to the Mercer team. Next, we'll do a quick review of the program goals and an overview of the current case rate structure. From there, we'll get into the content around the PY2 performance year 2 case rate updates, specifically what updates are going to be made to the case rates for next year, as well as a review of the rate calculations that are going into this process. And then we'll end with some next steps and questions. So Sean, I will hand it off to you.
All right, thank you. Hello, good afternoon, everyone. My name is Sean Thiel Sachs. I'm with Mercer and have partnered with all of you since the beginning of our maternity bundle design and rollout. And joining me today, who you will hear mostly from, will be Caroline Scott, as well as Eileen Bennett. They're our actuary team and our case rate gurus. So you'll be hearing from them in just a moment. So if you want to go ahead to the next, next slide. I'm going to briefly just mention and remind folks of our goals of the program, and then we'll get into our case rate discussion. So as a reminder, when we were putting this together, there were several goals in mind. Key and in the center was to strengthen that maternity health in the state of Connecticut's Medicaid program, and particularly through a focus of improved quality of care. All of that to be done within the structure of promoting health equity to really ensure that the design and implementation was targeting health disparity reduction. We also were looking to improve health outcomes with an enhanced flexibility to deliver person-centered care. And so moving into the model that we have today was a vehicle to help us do that. As part of that case rate structure and model, we are looking to incentivize high quality of care through performance-linked quality metrics, which we've talked about in previous sessions, and that you can access those materials online if you want to take a look at those outside of today's call. And really to ensure that we're increasing patient satisfaction with new coverage through the community, peer resources, and reducing unnecessary costs for greater efficiency and care coordination. That, as I mentioned, a key design was the case rate model that we're going to talk about briefly, and how that is linked to quality measures, and social and clinical needs, and giving flexibility for other kinds of access, such as doula and lactation support. And so really that next step of this process that we've been beginning to do is to ensure that we're also examining these services through the lens of race and ethnicity to ensure that we are close to our key goal of health equity and closing that equity gap. Right. I was going to pause before I pass it over. I saw a couple of things come through the chat. I'm sorry, Tiffany. I just want to pause a minute, make sure. Okay, this is a question that I think Caroline and Eileen will be getting to, so we'll log those as we go. But Fatmata or Tiffany, did you want to add anything else about our core goals and reminder of where this all leads back to before we get into the detail of our case rate discussions?
I think you highlighted it very well. Thank you. I have nothing to add.
Okay, so with that, we will move to the next slide, and I will turn things over to Caroline and Eileen.
Right, thank you. Next slide, please. So I'm going to give these slides a light touch since these are all materials that were shared during prior forums. But just reminding everyone that the Maternity Bundle program is seeking to utilize a bundled payment design. And so the bundled payment is essentially an alternative payment model that moves fee for service towards a uniform monthly payment. And that uniform monthly payment is intended to represent the anticipated total cost of care over the maternity episode. So as you can see in the graphic, under a fee for service model, every service that is delivered is reimbursed separately. Under the bundled payment model, the provider will receive a flat monthly payment for all patients in their care. And that represents essentially the anticipated cost from the beginning of the second trimester through 90 days postpartum. Under a bundled payment approach, it gives providers an opportunity to share in potential savings if costs are kept below the bundle's anticipated costs. It also allows the provider to assume risk if costs go above the target price. Next slide, please. And just a little reminder of the definition of an episode of care. So the Maternity Bundle program utilizes a look back process to define the maternity episode. So the maternity episode begins 280 days prior to the delivery and ends 90 days after delivery. Then 6 months after the program year has completed, there is a reconciliation process, and that's the opportunity where the provider may be able to realize shared savings. Next slide, please. Just a reminder of the services that are included within the case rate bundle. So when you look at your rates, these are the services that are included. Services that are outside of the bundle will remain fee for service. And then there are also some services such as the lactation support or the postnatal doula visits that can be either done via an enhanced case rate or as a fee for service. Moving to the next slide, please. So the maternity bundle program is essentially a hybrid approach where the case rate is determined prospectively using prior experience adjusted for acuity and then subject to a retrospective settlement. The initial case rates for performance year 1 were based on the cost for the providers between October 1st of 2022 and September 30th of 2023. Those costs were not adjusted for any projected trend, social risk, acuity, or change in acuity over years. At the end, the PY1 rates are going to be settled against emerging 2025 experience. So that reconciliation process will give providers an opportunity, as we mentioned, to realize shared savings. Those shared savings are subject to quality. And in future years, the state may choose to implement a shared loss model if the cost of maternity care exceeds the target price. Moving to the next slide, please. So the purpose of the case rate refresh, we want to make sure that we are moving towards alignment with the target price that we are going to be using for reconciliation. So as part of the target price process, there is an adjustment made to account for acuity and the statewide average cost. The target price is essentially a 50-50 blend of the provider's experience from the prior year, adjusted for acuity and statewide trend, and the acuity adjusted statewide average rate for all maternity bundle program practices. There is a little bit of nuance to the way the target price is established. So we do truncate to basically remove the high and low cost outliers. But we do want to sort of move towards alignment so that during the reconciliation, there's less volatility. And certainly we want to be mindful of not creating the potential for a negative under a two-sided model, a shared loss. So we are looking to phase in the risk adjustment in a way that's going to be comparable to the way we utilize risk adjustment in the target price. So our goal is to move towards a 50-50 risk adjusted case rate over 3 years. For year 2, we're going to implement 1/6 of the rate being subject to the case rate, to the risk adjustment. In performance year 3, it will be 1/3, and in performance year 4, it will be 1/2, so that we can make nice, steady progress towards alignment with the target price over time. We hope that this will minimize year-over-year disruption to the providers while ultimately aligning these two metrics. And then moving towards the next slide, I'm going to pass to Eileen. She's going to cover the updates that we made to the case rates.
Thank you, Caroline. Yes, so we made several updates to the case rates in the vein of aligning towards the final target price. One of the first ones that we made were updates to the family medicine practitioners, acquisition changes, and attribution logic updates. Providers have the option to include family medicine practitioners in their case rate, and 2 practices opted to include family medicine practitioners for performance year 2. We updated the performance year 1 case rates to include attributed services for these practitioners, as well as the base year member month estimates. For practices that opted to include family medicine practitioners, they may see a reduction in their case rate, but that is offset by the number of case rate payments. 5 practices were acquired by a participating practice between October 1st, 2022 and June 30th, 2025. However, we did account for 4 of these practices in our prior methodology. Only one of these practices was new in 2025. Finally, we also made several updates to the attribution logic for performance year 1, just to refine that logic and ensure that we're appropriately matching members to their practices. Next slide, please. As Caroline hinted at, we are moving towards using clinical risk adjustment using adjusted clinical groups. We are using the Johns Hopkins Adjusted Clinical Group Case Mix and Predictive Modeling System, or ACG, to assign risk scores to members in the Connecticut maternity bundle population. This is a statistically valid and diagnosis-based methodology, and it is helping to project a population's future health. The use of the ACG risk score was established in both the concept paper and the SPA, and the hope is to promote equity across providers, and those providers with higher risk ideally would get higher payments. Risk scores can be both clinical or social, and we are including a component of both of these. So the ACG risk score is the clinical component, and on the next slide, we'll see the social risk score that we've also included this year. We have some more details on the exact methodology on the later half of the slide. Every Connecticut Medicaid member is assigned a single ACG group, and We also normalize risk scores for all members. So we first normalize risk scores against the larger Connecticut Medicaid population, and then we again normalize again for the Husky maternity bundle population. This is because the Husky maternity bundle population has a much higher risk score than the average member in our population. Next slide, please. So as I mentioned, we have also implemented the use of social risk adjustment using the Area Deprivation Index, or ADI. The ADI estimates the average level of deprivation in an area. So ADI scores range from 1 to 10, and they represent a decile for each number. So an ADI of 10 would be the most disadvantaged 10% of neighborhoods. I want to note here that the median ADI for the Husky maternity bundle population is an 8. So the maternity bundle population has a much higher than average poverty distribution. Maternity bundle members with an ADI score of 9 will receive a 0.1 addition to their risk score, and maternity bundle members with an ADI of 10 will get an increase of 0.2 to their risk score. However, as I just said, because our median ADI for this group is an 8, the addition of the ADI doesn't have a significant change to the total risk score or to the total case rate payment. And one other note I want to add here is that risk adjustment is budget neutral. So any changes in singular provider risk scores and case rates will not affect the overall budget of the entire program. Next slide, please. Additionally, we repriced the 2022 and 2023 claims to the current fee schedule. This was overall a very small update. We reviewed and repriced for known fee schedule changes, but ultimately we did not see any major changes. So you can see here that there were only 14 physician and outpatient procedure codes that were included in the repricing, and all services were repriced to the obstetric fee schedule if available, but the majority of the codes were telemedicine services. Caroline will go through a detailed example later, but the overall impact of the repricing was a 0.0% impact. Next slide, please. We made credibility adjustments for practices with limited experience. As many of you probably know, under the current state plan, a practice must have 30 maternity episodes within a performance year to receive a case rate. Any attributed practice with less than 30 maternity episodes will be reimbursed fee for service. If a practice qualifies for a case rate, it is fully credible and we do no blending. And in 2022 and 2022 to 2023, every practice was fully credible. However, in 2025, we are seeing a few practices that are not fully credible. And in that case, we are blending with the statewide rate. Caroline will go through an example later where we show how the blending works for a small practice. The next slide, please. Finally, we updated the performance year 1 add-on payments to reflect performance year 2 selections. So providers had the option to select a doula service option prior to the start of every performance year, and we reviewed to see if providers opted in or opted out. Doula services received providers that opted into the doula services received a $14 per month add-on payment at the very end of our refresh process. And practices may also receive an enhanced case rate for lactation support, which is a $7 add-on payment. These are the same payment add-ons that were eligible to be received last year as well. So there was no change to the amount for these services. Next slide. Thank you. And I'm going to pass it back to Caroline.
Thank you, Eileen. Next slide, please. So I want to provide a little bit of information on the case rate refresh process. All practices were supplied with their summary that was delivered last Friday. Case rate development steps exclude the add-on payments for doula and lactation. Applicable add-on payment rates are in the final step. All percentage changes are relative to the current PY1 composite rate. No adjustments were made for delivery type blend changes between years. And the practice level examples that you're going to see today are fictional. They're provided to allow each provider to essentially reconcile their rates and are intended to be strictly illustrative. So in this example, we can see we have a fictional practice that is starting off with a composite rate of 395.89, and the all practice average is 401.61. We are including the member months to show for practices that have the family medicine acquisition or attribution update changes, any projected change in total case rate volume to those changes, but those calculations are not part of the math. They're informational only. Also, the delivery blend is not going to be part of any of the math steps. It's just simply provided for informational purposes, since we have noted that the vaginal rate is lower. Moving to the next slide, please. So for the first step of the case rate process, we start off with the initial performance year 1 case rate, and that was as paid in September. We remove the add-ons for the doula and for the lactation support, and that is our starting point. To determine the total program funding, we look at projected enrollment for the 2022-23 program year for all the projected practices, and that shows that the average case rate for the initial program year is $400.50 prior to add-ons. For most practices, the attribution updates were very minimal. Most practices show 0 here. As Eileen mentioned earlier, for practices that either acquired or opted in for family medicine, that is expected to result in a small reduction because those practitioners have lower billing rates, but that small reduction in case rate amount is expected to be offset by an increased volume of case rate payments. And then in the dark blue boxes below, you can see essentially the math steps walking you through how we've calculated all of our PMPM impact steps. I want to call out that the percentages are always going to be calculated relative to the starting rate so that they can be added so that 5% and 10%, 5% is always half of 10%, for example. If we change the basis, the percentages can be confusing. Next slide, please. Sorry, step 2. So our first step is the ACG risk adjustment, as Eileen mentioned. And as she mentioned, the composite risk score for the maternity bundle program is significantly higher than average. So as you can see, when we look at the maternity bundle program, we're right around 2.5% of the average risk score for the Connecticut program as a whole. So the next step is to essentially normalize those risk scores across the program. So we start with the ACG risk scores as received by CHN, and then we composite them across the program to essentially create a normalized risk score for the maternity bundle. So that is simply just dividing the provider's specific risk score by the composite risk score across the practice. And it should be noted that the risk score is for all members. We don't differentiate for vaginal and cesarean members. To calculate the risk-adjusted rate, it's going to be 1/6 of a budget neutral risk-adjusted rate and then 5/6 of the provider's own step 1 rate. So in this example, we can see that this provider has slightly higher than average acuity. So they're going to get their normalized risk score, the 1.005, times that statewide average rate, which is pretty consistently $400.50 throughout all of the steps. And so that's the portion of the rate that is risk adjusted. And then 5/6 is going to be their rate from the prior step. Next slide, please. In the next step, we integrate the social risk adjustment. So as you can see, when we add social risk, we are increasing the average risk score across the program. To remind everyone, members that have an ADI score of 10 receive an increase of 0.2 to their ACG mix, and those that had an ADI score of 9 receive an increase of 0.1. So as we look at these, we can see that we are seeing an increase overall. However, as Eileen mentioned, because the risk adjustment is budget neutral, we again normalize back to a 1.0. So in this particular example, this provider is seeing a relative increase in their acuity with the social risk adjustment because their relative acuity has moved from a 1.005 to a 1.007. So the calculations are the same as on the prior slide. The only difference between this slide and the slide prior is that the risk score is now inclusive of the ADI adjustment and normalized. Next slide, please. In the fourth step, we reweight the scores to the current year ACG scoring. And the reason why we are doing this is because we are doing an acuity adjustment between years. And during the continuous coverage unwinding, we noted that the average Husky non-maternity population saw an increase in acuity because healthier members were more likely to disenroll during the continuous coverage unwinding. So to avoid any issue with as you can see, the average risk score when we normalize again has gone down, and that's because we've had some changes over years. So we rescore that to the 2024 ACG group scores, and now this provider has a normalized risk score of 1.008. So we kept the same ACG clinical group that each member had. We simply put it on a common scoring year with the 2025. Again, the calculation is the same as before. So the provider's specific rate is going to be 1/6 their normalized risk score times the statewide average rate plus 5/6 of their step 1 rate. So always going back to that provider specific rate after the family medicine acquisition and attribution updates. Next slide. Step 5 was not a particularly eventful slide in the repricing. We did find 5 total claims that needed to be repriced, but overall it did not materially move any of the expenditures. But we did want to make sure that we were checking to see if there were any fee schedule changes. So as you're reviewing, you'll note that step 5 is the same as step 4. We did want to make sure that we were reflecting any projected changes to our fee for service cost. And then step 6. In step 6, we're applying a credibility adjustment for any practices that have fewer than 30 births during 2022-2023. So under the current SPA, a practice is eligible to receive a case rate if they have 30 births. We want to make sure that we are allowing new practices to opt in. So there were some practices that may not have had 30 births during 2022-2023. But all of the practices that are currently participating were found to be fully credible for the base year. So this step does not really move any of the metrics, but the way that we calculate credibility is essentially we look at the total number of maternity episodes that the provider has, and the formula is in the blue box. It's a fairly standard actuarial formula to blend in the provider's own experience and the statewide average. So in this case, this is intended to be a smaller fictional practice. They had 55 maternity episodes during the base year. You can see that that is above the threshold for credibility, but we do cap credibility at 100% since that's the most that you could have of your own. So in this particular example, they will get 100% of their step 5 rate. If they were not fully credible, they would be blended with the statewide average. So credibility is essentially for those smaller practices intended to reduce the impacts of variance, because we do note that our smaller practices have much more variance in their episode costs than our larger practices. Moving on to step 7. So in the next step, we apply emerging acuity. So we're looking at the practices. We looked at acuity scores for members that had a delivery during 2025 H1, and that delivery was attributed to the case rate. So for those reasons, because we have less than a full year of experience and because several of the initial deliveries were under global billing, we do have some of our practices that are not fully credible for the 2025 first half of the year. So in this example, we have a provider that's had 24 episodes during the first half of the year. So using the credibility formula, you can see that that provider is estimated to have a credibility of 89.4. When we look at their total score, that's going to, we're essentially taking their credibility and we're applying that to the raw risk score. So when we're taking their risk score, we're giving them 89.4% of their own credible experience, and then we're blending that in with 10.6% of the average statewide acuity that was observed during that period. And so that's creating our credibility adjusted risk score. We then take the credibility adjusted risk score and then normalize that because, as we mentioned, risk adjustment is always budget neutral. So in this example, if we look at this provider, through the process, we've seen that their relative acuity has increased to a 1.016. So that essentially means they're about 101.6% the cost of average. And so we, again, if we can move to the next slide. I ran out of room to show the calculations. So in this example, they're moving through and they have 1/6 of their own rate, or sorry, 1/6 of the credibility adjusted rate, and it's 5/6 of the statewide average. Moving to the next slide, please. For step 8, the PY2 add-on payments for doula and lactation. So at this step, we are taking the statewide step 7 rate. We are adding, if the practice has opted in for the doula support, we're adding $14, and we're adding $7 for the lactation add-on, and that's getting us to $418.15. Altogether, we have a total PMPM of a total PMPM change of $1.26 for this practice. On average, practices went down $1.12. That was due entirely to the family medicine update, as we mentioned earlier, and that is again expected to be offset by increased volume in case rate payment. So I will pause. I've gone over a lot of math. Are there specific questions on any of the math steps that I have covered so far? All right. Next slide, please. All right, and I will pass back to Tiffany to share next steps.
Thank you, Caroline.
Oops, sorry.
Okay, perfect. Geisha, I think we have a different slide for this, but I can go over this information. So we'll send out an updated slide with the correct date for this, but in terms of next steps, DSS values your feedback as part of this process in developing the program and also in implementing the program. A big step of this process has been listening to provider feedback and stakeholder feedback overall. So for that reason, as part of this process with the case rate update, we value your feedback and want to hear back from providers. There is an opportunity for providers to submit written feedback on your case rate. So you can do that by submitting your feedback to Kim Osno, our CHN contact. Her email is included below. We ask all written feedback to be submitted by November 21st. And that'll be considered as part of the case rate development Please don't submit anything verbally or after this date. This is a hard deadline, November 21st. When you're sending this in, if you could please use the maternity bundle PY2 case rate feedback as the subject line of the email, and also include your practice's name and tax ID number as in the body of the email, that would be great so we can get back to you. I'll also note we don't have time to cover practice-specific questions on your case rate, but if you are interested in having a discussion about what goes into your practice-specific rates, we can also set that up if you want to email either Kim, your PES representative, or the general maternity bundle email. And from there, we can go into our Q&A portion of the call. So I'm seeing some questions come in. I'll start with the one in the chat. I think this is a general question. Does anyone in this meeting work with Athena? If so, could you please work with me? They have some questions about how Athena is posting case rates. All right, so that can be a general call to this group. And in terms of tying episodes to payment, if you email Kim Osno, we can also work with you to kind of sort out any questions you have around that. Moving on to the Q&A, we have a question from Dr. Koppel. In the first example, the practice had a higher than average risk, but still had a lower than average PMPM payment. How does this work?
Thank you. So you are correct that when we look at the initial rates, we see that, for example, there are some practices that have higher than average acuity, but a lower than average rate. So it's worth noting that the original case rates are not adjusted for risk. They're simply a product of the fee-for-service charges that were incurred by the practice for all of the maternity bundle members. So the purpose of this refresh is to essentially move the rates in better alignment with acuity. So in this particular slide, as we look, we can see that we have a practice that has an average risk score of 2.469, whereas all the practices are 2.458. Because their risk is higher than average, they would see an increase under a budget neutral risk adjustment. So the way that a budget neutral risk adjustment works is that if the provider has either a higher than average acuity or a lower than average cost, they see an increase under a budget neutral system because it's basically using the acuity to project the total cost instead of just the total claims volume from the past. Did that answer that question? Hopefully, yes.
I'll speak up. No, but I don't understand this whole process the way you're explaining it. If somebody has higher than average acuity, it's going to take them, it sounds like 6 years or more to start getting paid more than average, even though they're providing care, presumably more intense care to patients with higher acuity.
Right. So the provider-specific case rate was based on the provider's historic cost of care, whereas acuity is based on the diagnosis for the member. So there are, while it is normal that higher acuity practices are going to have higher than average costs of care, in the aggregate, while that's true, it's not always true at a practice level. There are some practices that have higher than average acuity and lower than average costs because they build fewer services during the base year than other practices. So because the services are paid on a fixed fee schedule, and the fee schedule is is not adjusted for the member's acuity. It's basically a fee for every service delivered. That's how those initial rates are developed. And so what we're anticipating is that over time, with risk adjustment, we're hoping to align payments so that the providers that have the higher acuity members will see that increase over time. But certainly that's the purpose of the phase-in, is because we did see not perfect alignment between acuity and cost in the initial year. We wanted to minimize year-over-year change. Are there additional questions?
And if it's easier for folks, we also welcome you to raise your hand if you want to ask your questions live.
Thank you. And Tiffany, because I'm sharing right now, I can't see the chat. So if you can monitor that and let me know if there are any questions, that would be great. Is everyone able to see the screen that I'm sharing?
Yes.
Okay. Yes, you are certainly correct that there is not a perfect relationship between acuity and cost. So going back to sort of the initial goals that we discussed at the beginning of the meeting, one of our goals is to align total payment with the projected acuity of the member so that maternity bundle practices that are serving higher risk members will receive higher payments. And those payments will be adjusted so that essentially the money is moving towards the higher risk members. But yes, we did note that, as we mentioned, it's not a perfect relationship between acuity and cost because the fee schedule is more or less indifferent to the member's acuity. The rates are the same regardless of the member acuity. They're all billed on the same fee schedule. So while it is true on the average that higher acuity members do have more fee-for-service claims and therefore higher costs, it's not always true at the practice level. Are there any other questions?
No new questions in the Q&A or chat yet.
All right. So in terms of next steps, as Tiffany mentioned, I'll go back to that slide. We do have a feedback process. We would love to hear from you. So please submit all of your feedback in writing no later than November 21st. We want to ensure that feedback is submitted in writing so that we can fully understand any feedback received. We're also happy to arrange meetings with providers if there are specific questions about the materials that you received in your case rate letter. We're hoping that the sample calculations that were included with your case rate letter can help you in reconciling, but we're certainly happy to provide any support if you have any questions about how your individual rates were calculated. In terms of submitting feedback, Kim Osno from CHN is going to be our point person on the feedback collection process. We are asking, as Tiffany mentioned, that you please use the maternity bundle PY2 case rate feedback as your subject line, just to ensure that all of your feedback is properly categorized and received. And then in that feedback, again, please include your practice name and your TIN. There are no other questions. I will pass back to Tiffany to wrap us up.
All right. Thank you, Carolyn. So I think this concludes our meeting. Like Caroline said, we're happy to answer practice-specific questions, and we look forward to hearing from you if you have any additional feedback or questions. Thank you, everyone.
Thank you.
Thank you. Bye-bye.
Bye.